Hello, and welcome to today's webinar. Vitiligo is important, treatable, and has an exciting future, sponsored by Elsevier's Clinics Review articles and dermatologic clinics. Before we begin, please take a moment to answer our poll questions on the right side of your screen. Please note your line will be muted and the presentation will be recorded. You may submit questions at any time using the Q&A feature located on the right. Today's presenter is Dr. John Harris. Dr. Harris is an associate professor of dermatology at the University of Massachusetts Medical School and serves as director of the Vitiligo Clinic and Research Center at UMMS, focusing on both the clinical management of vitiligo patients as well as research into new therapeutic strategies. He and his team use basic translational and clinical studies that incorporate the use of mouse models, human tissues, and small clinical trials to determine disease mechanisms of vitiligo. The goal of their research is to identify quantifiable markers of disease activity and test new treatments. Thank you for being with us today, Dr. Harris. Please go ahead.
Thank you, Tammy. I'm glad to be here. I also want to thank the editors and staff at Elsevier for the opportunity to give this webinar presentation on vitiligo. While I've given a number of presentations, I've never done a webinar before, and it's a really exciting new medium to provide information on important topics with a far reach all over the world. I have a limited time today and plan to take you through a whirlwind tour of the April issue of Derm Clinics on vitiligo. I won't have time to get into great detail on individual topics, but direct you to the April issue for more depth, or this month's CME article in the JAD, which is a distilled version of this important information. Next, I want to thank all of the amazing authors that contributed to this issue, each of whom I consider a world-class expert in vitiligo, as well as close friend. These authors are distributed around the world, representing a diverse group who worked very hard to create the information I'll summarize in this presentation today. In addition, we need more vitiligo experts, so if what we talk about today excites you and you're a dermatologist, join us and help us take care of the many vitiligo patients who deal with this every day. I'm going to begin with Dr. Nordland's chapter on the history of vitiligo. Dr. Nordland was around at the very beginning of modern research in vitiligo, and so I was thrilled that he agreed to write this chapter. The first slide here shows in Table 1 the options, the historical treatments that patients have used for vitiligo, and more than anything, I think it speaks to the importance of vitiligo to patients and to what lengths they're willing to go in order to get rid of it. So what I've outlined here in red are just some of the very surprising treatments that people have used: corrosive sublimate, escharotics, which create scabs on the skin, hydrochloric acid, thermal and caustic blistering, and vesicants. And fortunately, we don't need to use these today. We have much better treatments, and those are also outlined here in this table. But again, I think it really speaks to the importance of this disease, that patients will go to great lengths to treat it. The next slide is really summarizing one of the topics that he addressed in his chapter called PUVA, or psoralen plus UVA. It's both a very old treatment and then also one of the first modern treatments that we use. I outlined it here in the Atharta Veda in India. This was in the chapter described. Over 2,000 years, 3,000 years ago, you can read, if you can read the original text, which most can't, I assume. It talks about this plant called Psoralea coralifolia and its seeds called bavachi seeds. These are black seeds that patients at this time, again, over 3,000 years ago, would chew on and sit in the sun and treat their vitiligo. Essentially, what was in the seeds was psoralen, and in modern times, Al-Masti was really, in Egypt, was the first to describe this as a modern therapy. He isolated the psoralen out of plants and gave it both topically and orally to patients, and then published that this was an effective treatment for vitiligo. And it was really the first one in the modern literature to show efficacy for the disease. It was further studied and popularized by Drs. Lerner and Fitzpatrick just a few years later. And Dr. Nordland shows one of his patients in the top left and top right, before and after PUVA, showing what a great treatment this was. We don't use this treatment anymore. We'll talk more about kind of the more modern approaches to therapy later. Next, I want to talk about the quality of life and comorbidities and systemic effects of vitiligo. In summary, it's an incredibly important disease to patients. And you can see here, again, going way back in India to the Rig Veda text at around 1500 BC, it stated that persons suffering from vitiligo and their progeny are disqualified from marrying others. And this is not just an ancient problem, this is a modern problem. So you can see just a clip that I put up there from 2013 on the web, published in India, also stating that young people were having a very difficult time finding spouses and people to marry. And so this one stated a white spot on this young woman's hand played the villain, and marriage proposals reduced to a trickle when people found out that she had vitiligo. So this is a modern problem, and vitiligo is incredibly important. The next slide I show just a paper that was published that really looked into this, the burden of vitiligo on patients, and their conclusion was generalized vitiligo is a serious skin disorder with an adverse impact on the emotional state, comparable with that of other major skin diseases. And so I want to highlight that on the right in another study that shows the Dermatology Life Quality Index. This measures how satisfied people are with their life and how affected they are by it. And I show the summary of this data in both vitiligo and psoriasis patients. And the details are not that important. Essentially, that pie chart shows you those that are not affected at all, mildly affected, moderately affected, severely affected, and very severely affected. And the take-home message is if you look at those who are very moderate to very severely affected in both vitiligo and psoriasis, the numbers are about the same. And so vitiligo patients are just as affected as psoriasis patients by their disease, and therefore they deserve all the attention and the treatments and therapies that we can give them, equivalent to what we do for psoriasis patients, which is quite a bit today. Next, we'll talk about the fact that melanocytes are not just located in the skin and the hair. They're actually found in the inner ear, as well as the retina of the eye. And this is important because 12 to 60% of patients with vitiligo actually experience hearing loss, and we think this is due to loss of melanocytes in the inner ear as well. And 16% have ocular abnormalities, whether that's upon examination or visual changes. And so this really speaks to the fact that vitiligo is more of a systemic disease than many realize. It's not just skin and hair. On the right, I talk about two rare variants of vitiligo. One is Vogt-Koyanagi-Harada syndrome, named after the doctors that first described it. And it begins with the prodromal flu-like symptoms and meningitis, headaches, and then moves on to affect the eye through a uveitic stage where patients get blurred vision and an inflammation called uveitis. And then after that, vitiligo, poliosis, or white hairs, and alopecia appear. And then the chronic phase, in addition to the vitiligo, which stays around, is the eye inflammation, which can make patients actually go blind, and they require systemic immunotherapy. And so Vogt-Koyanagi-Harada syndrome is important to recognize. It's a rare variant of the disease, but it's pretty severe. And it probably results from attacking melanocytes in the other organs we talked about. In addition to the eye and the ear, the melanocytes are in the meninges of the brain as well. And so Alessandrini syndrome is very rare. I've seen one patient with it. It's only been reported 8 times in the literature. And it's characterized by unilateral depigmentation on the face, which is essentially segmental vitiligo on the face, with prominent white hairs or poliosis, and then ipsilateral retinitis and hearing loss on that same side. And I can consider this a variant of Vogt-Koyanagi-Harada or a segmental form of Vogt-Koyanagi-Harada syndrome. And so, in summary, it's really important to recognize that vitiligo is not just hair and skin. It can affect other organs and be a systemic disease as well. The next slide is talking about other diseases that can go along with vitiligo, comorbid autoimmune diseases. And Table 1 shows a list of other diseases that have been associated with vitiligo in patients. Really, in the red box, I've highlighted the most common ones: thyroid disease, including Hashimoto's and Graves' and others, alopecia areata, type 1 diabetes, pernicious anemia, and atopic dermatitis. Thyroid disease in the general population is about 3% incidence, but in vitiligo patients, it's about 20%. So that's increased quite a bit. And other diseases are increased likewise. So this is probably because of shared genetic factors between vitiligo and these other diseases. In the top right, Dr. Elsevier is showing vitiligo depigmentation along with atopic dermatitis in the hands of this patient. This is very common, particularly in children. And then I'm showing below that, on the top in A and B, a patient with vitiligo on her skin and alopecia on her scalp. This was both diseases in the same patient, which is not that uncommon. But below that, I show yet another patient who had vitiligo and alopecia areata. But what was interesting was both diseases went to the exact same spot in the skin. And so if you look at the border of the pigment in that skin, it follows the border of the hair loss as well, really suggesting that these two diseases are running on the same fuel and that there's a really significant correlation between the two. So next I want to talk about skin cancer risk. That's the next topic in the book. And this comes up a lot. Patients ask about this a lot, and it's reasonable to assume that if you lose the pigment in the skin that you're not, therefore no longer protected against the sun, and that skin cancer risk could go up. But recent studies actually show this is not the case. Dr. Rodriguez outlines a number of the studies in Table 1 that have been published. And the more recent studies really show, more recent studies with more patients show that the risk of melanoma and non-melanoma skin cancers is actually decreased in vitiligo patients. And about threefold lower risk for melanoma and non-melanoma skin cancers, including basal cell carcinoma and squamous cell carcinoma. The decreased melanoma risk is not too surprising because vitiligo is an immune attack against the melanocytes. So if they become a melanoma and become abnormal, they're attacked, and this is done very well in vitiligo patients. The reason why non-melanoma skin cancers would be decreased is not currently clear. But I use this as one of the good news pieces that I can tell my patients that they appear to have a lower risk of cancer. Now, this does not mean they have a zero risk of cancer. That's important to highlight, and patients can still get these cancers, but they don't appear to be at an increased risk. She also, in this chapter, touches on the fact that patients with melanoma who develop vitiligo actually have a better prognosis. This can happen spontaneously. Patients with even widespread melanoma, stage 4 melanoma, if they develop vitiligo, many of them actually recover from this devastating cancer. And then more recently, we've found that those who are treated with immunotherapy, melanoma patients, such as PD-1 inhibitors and others, many of them get vitiligo after the treatment, and then this actually suggests a good treatment response. And so this is an important aspect to recognize. There appears to be an inverse correlation between vitiligo and melanoma. The next topic we'll talk about is presentations of vitiligo, what it looks like, how to tell if it's active in your patients, and what other diseases can look like vitiligo, what to be thinking about when you're looking at patients. The first slide just shows vitiligo in the face in two patients. This is very easily recognized, and as you can imagine, very difficult to hide by these patients, and so there's no question that this can be psychologically devastating. It begins as tiny macules of depigmentation. You can see here on the arm of one of my patients, there are two very tiny spots of vitiligo. These grow and coalesce into larger spots, patches and macules. This is a characteristic appearance on the hands of a patient. This vitiligo depigmentation can become really very widespread. As you can see in the next slide, the patient has widespread vitiligo all over, and this can be psychologically devastating for patients. In the next slide, I'm showing the fact that vitiligo depigments the skin, but frequently spares the hair within the skin. So melanocytes give pigment to both the skin and the hair, and sometimes the hair is protected through immune privilege, we think. And this is actually a good sign for response to treatment. This is a better prognosis. We'll talk about why later, but it's because the melanocytes crawl out of the hair follicle back into the skin to bring the pigment back. However, hair can become depigmented. This is what we call poliosis. This is in the axilla or armpit of a patient. You can see white hair. You can see normal hair color. And when this happens, that means the pigment cells are no longer in the hair, and it makes it much more difficult to treat and get the pigment back. Vitiligo is one of the diseases, like others, that Kebnerize. So other diseases, including psoriasis, lichen planus. Vitiligo will do this as well, named after Dr. Kebner, who described the fact that if you injure the skin, some skin diseases will actually go to that location. This is a mountain biker who falls off his bike a lot, bangs up his shins, and the vitiligo goes to that spot. So you can see lots of vitiligo in this patient's shins. The next slide, next topic really is talking about how to recognize if vitiligo is active or stable. And so there are 4 appearances of vitiligo, 4 clinical signs that you can look at that really tell you the disease is active. This is, of course, in addition to asking your patients, who will be able to tell you that they're getting spreading of disease and new spots all the time. These are the pictures that are included in the chapter. You can see on the right, actually, are tiny macules of depigmentation on the hand. This is what we call confetti vitiligo, and is a sign of very active disease. These spots will grow into larger macules and patches, and patients will get rapid spreading of their disease when you see this. On the left is showing some of that, some confetti, some lines, linear depigmentation as well. That's Kebner phenomenon. I show in the next slide some of my own slides to really outline it. Top left, you can see trichrome vitiligo. There are 3 colors that you can see here. You see the normal skin, you see the depigmented skin, and then you see something in between, hypopigmented skin. These are 3 colors, so we call it trichrome. You can actually, in this picture, see a little bit of confetti vitiligo toward the bottom as well. The bottom left is inflammatory vitiligo, and I'm showing an image given to me by Dr. Shyam Verma in India because it's such a great example of this phenomenon. It's actually a very rare appearance of vitiligo, form of vitiligo, because it only lasts for about 2 or 3 months when it occurs. And the characteristic appearance of this is erythema and scale at the border of the lesion. This might look a little bit like discoid lupus. It's very transient and results in vitiligo once it calms down. But I've seen patients with all these forms of vitiligo increase their body surface area. They can even triple their body surface area in just a few months when these forms are occurring. So they're important to recognize. Confetti vitiligo, we talked a little bit about. They're tiny macules of depigmentation that like to cluster around larger patches. This is an example on the abdomen of a patient. And on the right is example of Kebner phenomenon, where you see linear depigmentation, lines of depigmentation where presumably the patient was scratched their skin and the vitiligo went there. You can also see lots of confetti around that as well. So when you see these 4 signs, this really indicates that the patient has very active disease, and you should strongly consider using oral pulse steroid therapy. We'll talk about that later. Next, we'll talk about the differential diagnosis, the mimics of vitiligo. The bottom left, I'm showing pityriasis alba. This is a very common form of lighter skin. Patients come into clinic all the time, into my vitiligo clinic all the time, wondering if they have vitiligo. It's pretty easy to recognize. It's common in children on the cheeks. It's hypopigmented, not depigmented, and usually the patients have an atopic diathesis anyway, and so it's pretty easily recognized, and this goes away just with moisturization. On the right is lichen sclerosus erythrophicus, much less common inflammatory disease that looks like vitiligo. It is also hypopigmented and not depigmented. This is showing extragenital lichen sclerosus. Genital is much more common even and can be very difficult to distinguish from vitiligo. It can become depigmented in the genital area. Lichen sclerosus in women occurs in an hourglass pattern around the introitus and around the anus, and that pattern is very characteristic with atrophy as well, whereas vitiligo is more a haphazard pattern and doesn't appear to follow that strict figure 8. It's important to recognize lichen sclerosus because it can be aggressive, and aggressively treating it avoids long-term problems in the future. Next is idiopathic guttate hypomelanosis. It's a lot of words to say. I always get tripped up when I try to say it in clinic and tell patients what this is. This is incredibly common. It occurs on sun-exposed skin. It's very common on the legs and the arms, and consists of tiny macules of primarily depigmented skin. Those macules never grow beyond a few millimeters, and so their stability really indicates IGH rather than vitiligo. In addition, if you look, this is very evenly scattered over the surface of the skin, whereas confetti vitiligo likes to cluster and be present around larger patches. So that's generally how we tell the difference. On the right is progressive macular hypomelanosis. This is an idiopathic disease with hypopigmentation. It is not depigmented. It tends to be on the chest and back. Pathogenesis is really unclear, although some think it may be due to a form of P. acnes present on the skin. It is not vitiligo. It's pretty easily distinguished from vitiligo because it's hypopigmented. Next is, on the left here, discoid lupus. This can depigment the skin for sure, but generally results in dyspigmentation rather than depigmentation strictly. There's also hyperpigmentation there. The borders are irregular. There's alopecia that goes along with it. And so generally it can be distinguished clinically. Certainly biopsy helps. Chronic GVH, we don't see all that much, but as you can see, it can look like vitiligo, causes depigmentation, but there are usually other clinical signs that are apparent, and certainly the history of the patient will tell you that bone marrow transplant with chronic issues and complications from it are present. Next slide on the left is tuberculoid leprosy. This is hypopigmented skin with here you see an erythematous border. Clearly the hyposthesia or numbness in the area is an indication that this isn't simply vitiligo. Also is hypopigmented and not depigmented. This may be why there's such a social stigma around vitiligo in India, where leprosy is more common, and certainly a biopsy helps to distinguish and determine that this is not vitiligo. Tinea versicolor on the right, of course, is another infection that is much more common. This we see a lot. It is hypopigmented as well, not enhanced by Wood's lamp. You can elicit a fine scale, sometimes with a little elicitation with scratching, and certainly a KOH shows the presence of the fungi. It's easily treated with topical antifungal, either shampoos or creams or orals, and so it's important to distinguish this. I've had many patients come in with vitiligo and tinea versicolor, afraid that their vitiligo just spread all over their back and chest, and the good news is we could get rid of the tinea versicolor pretty quickly. Next is an important disease to keep in mind because it's uncommon and will often be referred as vitiligo. This is hypopigmented mycosis fungoides. This is a lymphoma in the skin, and so it's important to recognize and treat appropriately. It tends to occur on sun-protected skin and is also hypopigmented, not depigmented. And you can see sometimes some atrophy in wrinkling of the skin in these areas. I've had one patient who was referred to me for vitiligo who we recognized as having mycosis fungoides. Next is piebaldism. This is usually pretty easy to recognize. Families are aware of this because it's inherited in a dominant fashion, runs through families. This is depigmentation on the frontal ventral midline, and you see islands of sparing within these lesions and prominent poliosis in the spots. So this is not repigmentation of vitiligo, it is islands of sparing with piebaldism. Again, this is present at birth and families are aware of it. So next we'll move on to a variant of vitiligo called segmental vitiligo. And I tell patients who have segmental vitiligo that I have good news, bad news, and good news. We'll talk about that. So the good news about segmental vitiligo is it remains local. Usually will only stay in one area and not spread to any other part of the body. There are exceptions, but that's the rule. I think it's very important to recognize that segmental vitiligo is not in a dermatomal distribution. This has been a term that's been used for even decades, and it's just not correct. So if you look at the distribution of segmental vitiligo, it rarely, if ever, follows a dermatome. Top left is one of my patients with depigmentation on the chin and neck. It's actually running perpendicular to the dermatome, so in the exactly wrong direction. On the top right, you can see multiple dermatomes being affected. So while it is unilateral, it is not dermatomal, and you can see that in the patterns in the image to the right as well. That's included in the chapter. So we have to stop using the term dermatomal vitiligo. It's just incorrect. Segmental vitiligo has an early onset, often in kids. We see it often. And it evolves over about 6 months and then completely stabilizes for the rest of the life of the patient. And so sometimes just by history, a patient says, you know, the spot evolved so fast over just a few months, and I thought it was going to take over my whole body within a year. But then after 6 months, it just stopped, and I haven't had any new spots since. That's characteristic presentation. Segmental vitiligo involves poliosis, often early, not always, but a lot of patients will get early poliosis in the spot, which is probably why it is much less responsive to medical treatment. So that's the bad news. Although we do have success repigmenting patients with topicals and phototherapy, it is just much less responsive. It's more common to find patients who've tried these and it had no benefit. So that's the bad news. But then the final good news is that this form of vitiligo is very responsive to surgical treatment, and we'll talk about that later. In fact, it's a cure for this form of vitiligo. So next I'll talk a little bit about probably a highly unrecognized form of vitiligo called chemical-induced vitiligo. I think that it's a topic that's just not recognized by dermatologists, and I think it's important to do so we can optimize management for our patients. The first time this was described was in 1939 in a group of factory workers who were working in a leather tanning factory, and the workers were wearing gloves, rubber gloves, to protect themselves from the chemicals, and many of them depigmented underneath the gloves. And then a subset of those developed patches of depigmentation characteristic of vitiligo on other areas of their body that were remote from exposure to the gloves. And Dr. Oliver and his colleagues went in and found that monobenzyl ether of hydroquinone was a chemical in the glove that was responsible for this depigmentation and actual induction of vitiligo in many patients. In the 70s, this was actually the same chemical was put into a cream and is currently the only FDA-approved treatment for vitiligo. We'll talk about that later. But this is a drug that Michael Jackson used. This is a copy of his report, his autopsy report, that showed that many tubes of Benequin, or the brand name for monobenzone, were found in his house, and he was using them to depigment his skin. And again, this is a bona fide therapy for vitiligo. It's the only FDA-approved treatment, and this is why Michael Jackson depigmented his skin and turned white, because he also had evidence of vitiligo, again, on autopsy. So chemical-induced vitiligo is a real thing. It's an important thing that has been recognized. In fact, we take advantage of it to treat patients. And I'm showing some examples here from my colleagues, my former professor, Dr. Bill James, colleagues Dr. Inbal Bronstein and Dr. Paul Grimes, showing examples here of depigmentation around the hair in a patient who dyed his hair, depigmentation in the straps of the sandal area. This is due to latex in the sandal rubber straps. And then depigmentation of the goatee in a patient who was dyeing his hair by Dr. Grimes. And in collaboration with Dr. Qureshi and his group, they published a paper that we contributed to, identifying that the use of permanent hair dyes actually increases the risk of vitiligo. So if patients use permanent hair dyes for more than 5 years, or they start at under the age of 30, their risk of vitiligo goes up by 50%. So this is not a huge amount, because the risk of vitiligo is about 1 in 100. If you use permanent hair dyes, it's 1.5 in 100. But it does speak to the importance of chemicals in inducing vitiligo. The hair dye companies know this, and there are warnings on their boxes. One says that this can cause temporary or permanent skin depigmentation, and to be careful. Another one says don't use this if you have a condition called vitiligo. It can worsen that. And so this is important to recognize, because a lot of our vitiligo patients are using hair dyes and want to use hair dyes to cover up the poliosis that occurs. I don't tell my patients they can't use these hair dyes. I think it's up to them, but they should be aware that there's a potential that it could cause activity of their disease and spread. And I have about 50-50 of my patients. Some of them choose to stop it immediately. Some of them are willing to accept the risk in order to dye their hair. A more recent important phenomenon is recognition that kids are getting vitiligo from using a patch of methylphenidate, methylphenidate transdermal patch. So kids with ADHD often take Rhododenol orally to help them focus, and the same drug, methylphenidate, as is used in Rhododenol orally, can be used in a patch. And over 52 cases of patients were reported to the FDA depigmenting underneath the patch, where the patch is applied on the hips. And then a subset of those were developing depigmentation in other areas as well that were not contacted with a patch, and these spots were characteristic of vitiligo. I'm showing a case on the right, again, depigmentation on the hip, you can see with Wood's lamp, and then on the neck, remote from that area, showing that this patch induced vitiligo in this patient. And so this is important to recognize. If you have patients who are using the patch and you see vitiligo only on the hips in their children, this is an important question to ask. Also in 2013 in Japan, Kanibo made a skin lightening cream, and many bought the skin lightening cream and started using it. and there was an outbreak of vitiligo from using the cream. Over 18,000 people reported getting vitiligo, and so then it was withdrawn from the market, recalled, and studies have been done, and the active ingredient in this cream was rhododendron, and it appears that the mechanism, the reason why rhododendron caused vitiligo, was its close similarity to tyrosine. So it acts as an analog of tyrosine, and the reason that's important is because the amino acid tyrosine is the building block of melanin that melanocytes use to create pigment. And so melanocytes are confused by these chemicals. The other chemicals, the hair dyes and things, have similar chemical structures to rhododenol and tyrosine, and therefore they get confused. They try to use the chemical, and it causes problems. So here's a diagram of that, an illustration of what happens. In the top corner, you can see the amino acid tyrosine getting taken up by the melanocyte, converted by tyrosinase into melanin and pigmentation, whereas rhododendron, gets taken up, interacts with tyrosinase, but then causes problems in the cell, including cellular stress, which leads to inflammation and autoimmunity. And so this chemical-induced vitiligo, there's still plenty we don't know about it, but the fact that it exists is important to recognize. If you see interesting or strange patterns in your patients, they're using topicals, or it's in the presence of patches, it can be diagnosed, and then when the chemical is stopped and treated with vitiligo treatments, the patients get better. Other examples include chemicals in adhesive resins in bindi, worn in India, people depigmenting underneath that, wallets, where people put wallets against their skin, that can depigment as well. So this is important to recognize. So next we'll talk about medical treatments for vitiligo and how to maintain benefit and prevent relapse. And so here I'm just showing a schematic that Dr. Passerone put in his chapter, talking about the decision tree and how we treat vitiligo. You can see one of the most important aspects of the decision tree is whether or not patients have the segmental variant. If they have the segmental variant of vitiligo on the left, then certainly medical approaches can be tried, and we have seen benefit to that. But if they do not respond to topicals and phototherapy, then surgical approaches are appropriate. And we'll talk about those a little bit later, but they can even be used as a first-line therapy, particularly if the segmental vitiligo has lots of white hair, poliosis, which suggests that it's unlikely to respond to treatment, or if the patients have used treatments in the past unsuccessfully. So then if it's not segmental vitiligo and it's classic vitiligo that's present on both sides, then the first question really is whether this is active. If it's active and you see signs of activity that we discussed before, providers should seriously consider using systemic steroids to halt progression. You can save doubling, tripling of a patient's body surface area of vitiligo with 3 months of oral pulse steroids. And then these patients certainly need to be transitioned to phototherapy that can treat their whole body. And so that's the plan. If it doesn't appear to be active, then the pulse steroids can be skipped. And if it's localized disease, topical steroids are a good first start. Excimer laser, which is a localized therapy, is an option as well. And if it's widespread, then narrowband UVB phototherapy is ideal. And this can be combined with topicals as well. Of course, you're always reassessing the patient, and if they're doing well, you continue it until they plateau and they've got a good response. Then you can consider maintenance therapy. Dr. Passerone actually described using protopic or topical tacrolimus just twice weekly as a maintenance therapy to prevent relapse of patients. Or you can let the disease come back a little bit and start treating it again. Those are all options. It's important to recognize that the treatments we have currently are not cures, and so we have to do some kind of maintenance therapy or retreatment once the disease comes back, which may take years in some patients. If you're not getting the response that you expect, then you have to reconsider the protocol that you're using, make sure you're doing it correctly, make sure the patient isn't using a moisturizer with sunscreen in it unintentionally. Sometimes that happens and the light therapy doesn't get through. But phototherapy and topicals are very effective treatments. If the patient has very widespread disease, we call it universalis, typically this is around 80% depigmentation, then you can consider depigmenting the skin, going the other way with monobenzone, which again is the only FDA-approved medical treatment for vitiligo, which evens the skin and makes people happy. We'll talk about that a little bit later. Next, phototherapy. This is an in-depth chapter that was well done, just like all the others. But this is a long topic. And here I'm just not getting into the details, but just showing the success rates of phototherapy. Here I've highlighted most patients want to get 75% or more of their pigment back. That to them is a satisfactory response. And you can see that narrowband UVB does this around 50 to 60% of the time. And these are just different studies that are outlined, and you can look at this table in more detail in the book. But there is very high efficacy of narrowband UVB, and we don't use PUVA anymore, oral or topical, generally because it doesn't work as well as narrowband UVB, and there's a higher risk of skin cancer when using that. And so we feel more comfortable using narrowband. Remember these numbers that lots of patients get better with this treatment. The treatment must be done correctly, and so it's got to be a relatively aggressive protocol when using it. And so here's a great summary that we published just recently in May in the JAD, talking about the recommendations for how to use UVB in phototherapy and vitiligo. So there are some nice guidelines in there, and the guidelines are actually included in the clinics chapter as well. You can see them both places. One of the points that was highlighted is that the correct dose of narrowband UVB for your patients should turn their lesions, their spots, a little bit light pink. Dr. Pandya likes to call this carnation pink. You can see in the top left. And this should be asymptomatic. It should last for less than 24 hours. But this is the appropriate dose. You can see just right, just a little pink. On the top right and bottom left in B and C are too pink. These are turning red. These are symptomatic. And in the bottom right, there's not enough erythema there to be a proper dose. So this is how we generally look at response to treatment. In the next slide, just showing some responses that were included in the book. The excimer laser, that's a form of localized UVB therapy in a laser form, was very effective in this area of the knee. Note the dark hairs that were present there and permitted repigmentation. On the right is actually segmental vitiligo that responded to tacrolimus topically plus sun. It didn't respond completely, but the remaining amount is a much smaller spot that can then be treated by surgical therapy. Next, I'm just showing some examples of what we expect with successful treatment. This is a spot that has a bunch of little brown macules in it. This is repigmentation. These will continue to grow until the whole area is brown again. In the next slide, I'm showing that these spots are really perifollicular. They come from the hair follicles. And so that's where the reservoir of melanocytes are to repigment the skin. That's important because actually the next slide is you don't need black hair, so they just need to be normally pigmented. So this is a blonde patient with blonde hairs that are nicely repigmenting as well. Sometimes it's difficult to tell the difference between white poliosis and blonde in patients, and a Woods lamp can help highlight that. The next slide really shows the importance of having normally pigmented hair follicles. So this is on the lower leg of a patient who has some poliosis and the number of normally pigmented hairs. You can see the pigment is only coming back from the pigmented hairs and not the white hairs. And so this shows that the poliosis is kind of a poor prognostic sign in that area at least. Generally, I find if the poliosis is scattered and you've got at least 50% normally pigmented hairs, that's usually enough to repigment the whole area if there's a dense hair follicles there. The next slide shows the foot of a patient who is getting some repigmentation, but because this is glabrous skin with no hair follicles, the repigmentation is from the margin. This is marginal repigmentation. And the trouble is that marginal repigmentation can only really migrate a few millimeters, and so it's difficult to close this whole spot up without using like a surgical approach once it's stable. And it's important to set expectations for your patients and tell them that their hands and their feet, their volar wrists are going to be very difficult areas to get pigment back. The next slide is just showing nice repigmentation on the abdomen of one of my patients who had a completely depigmented abdomen, and then after phototherapy repigmented, and this goes on to completely erase the area so that it's difficult to tell there was ever any vitiligo there. The next slide is another patient who got phototherapy over time, and you can see on her neck and chest she responded beautifully. After 14 months, she said she was wearing low-cut dresses again and was very happy with this response. And in fact, what I'm not showing for privacy is that her face responded beautifully as well, and that was completely repigmented by around 6 months, to the point where I forgot she even had vitiligo on her face. She had to remind me. So she got just a great response, and she was very happy with us. So then the next slide is just my very simple medical treatment algorithm. First, I ask if there are any signs of activity. If so, then I consider oral pulse steroids. That can be done as prednisone, 20 milligrams every other day, or dexamethasone, 4 milligrams on Saturday and Sunday, just on weekends. So do that for about 3 months until we get them really on a therapeutic dose of phototherapy. If there are no signs of activity and there aren't more than just a couple spots, we'll use topical treatments. I use clobetasol twice a day for a week, and then tacrolimus twice a day for a week, and keep alternating that way, back and forth. That seems to eliminate the side effects of long-term clobetasol use, and it's highly effective. If they do have more than a few spots, and then we ask if we can get them into narrowband UVB, and this depends on locations of where they live, and if they're close to a center that offers it, and as well as their schedule. And if they can't do narrowband UVB, then they can do topicals in the areas that matter most to them. They could consider excimer laser in local areas. But if they can do narrowband UVB, I try to get them on that soon because it's the highest efficacy treatment we have. If they're willing to apply topicals as well, we add that in and do both narrowband UVB 2 or 3 times a week, as well as the alternating topicals. Importantly, on sensitive skin, like the face and the genitals and the underarms, intertriginous regions, we don't use clobetasol. We only use tacrolimus throughout. If they don't want to use topicals, that's okay, because narrowband UVB actually is quite effective anyway. And so that's my approach. Next, I want to talk about surgical therapy, which is a newer therapy that really is fantastic for the right patient. And so the first table here is really summarizing the proper patients, how to select patients for this treatment. Patient selection is critical. The key is disease stability. The disease has to be stable. So segmental vitiligo patients do great because by definition their disease is stable, usually after around 6 months. And if you find these patients, then lesions on the face and neck generally respond better than those in the trunk, and which respond better than the extremities. You can look closer at the table to look at all the key features of how to select patients for the disease, for this treatment. The next slide really just shows a great response to surgical treatment, and this is generally will last for the life of the individual. This is long-term treatment. We can even say a cure. Generally, when we get this type of response in segmental vitiligo, the disease does not come back, and no other treatments are required after a period of time. So next slide, I'm just showing some of my slides on one form of surgical therapy. You can read in detail about all the options in the book, but MKTP is emerging as really the best, highest efficacy with the lowest side effects. This is Melanocyte Keratinocyte transplant procedure. We're showing how it's done. This is a patient who did not have segmental vitiligo, but she had highly stable disease on her back. We outline the lesions, dermabrade them, and then next take a very thin graft from the thigh or buttocks in a protected hidden area. That graft epidermis is digested with trypsin and pulled apart into a single-cell suspension that's centrifuged down and then resuspended into a very small volume of normal saline or lactated ringers. And then that is dripped onto the dermabraded areas, bandaged up, and patients get a nice response after about 6 to 12 months. This should be aware of this because this is a great option for segmental vitiligo patients and those with stable disease. Next is a chapter on how repigmentation occurs. I'm just going to show one slide here. There are different patterns of repigmentation. You can see perifollicular on the upper left, marginal on the upper right. We've already seen some of that. There's kind of a diffuse that occurs. You can see in the middle where you can't really tell where the pigment's coming from. On the bottom left, you can see perifollicular and some marginal. And on the bottom right is repigmentation of the palms, which is interesting because it's a spotty repigmentation, but there are no hair follicles there, and we're not exactly sure where that pigment is coming from. It may be the sweat glands. On the right is just an illustration of where the melanocytes come from in the bulge, probably of the hair follicle, and you get perifollicular repigmentation as well as marginal repigmentation from the edge. Depigmentation therapies are important to consider. Monobenzone is really all I'm going to talk about today. There are others that have been published, but monobenzone is FDA approved. On the right is a sample consent that's included. Dr. Grimes included this in her chapter. You can print this out and have patients sign it. It reminds you to tell them all the important features of depigmentation. Here are some examples. On the left, nice results, depigmentation. In the middle, the face is depigmented. On the right is showing that monobenzone can cause contact dermatitis that can be treatment limiting. Sometimes you can get away with decreasing the concentration of monobenzone or using steroids along with it to try to decrease this effect. It's important to tell your patients that this should be considered irreversible. So you can't depigment today and plan to just repigment next year. That might not work. Sometimes there will be perifollicular repigmentation. The hairs seem to be spared with this treatment with sun exposure, and so retreatment might be important to keep the skin depigmented. You cannot just depigment one spot of the skin. You have to, as soon as you start using the cream, it works all over. And you should avoid direct contact after application with other people because this can induce vitiligo, remember from our earlier slides. Most patients who use this are very happy with the outcome, and remember it requires careful sun protection because the pigment is gone. So special things to think about in kids, segmental vitiligo is more common in children. They more often have a family history of autoimmunity, so think about that and ask about that. Differential diagnoses include nevus, depigmentosis, and lichen sclerosis. We talked about that one earlier. Try to avoid kevnerization, although it's hard. Kids like to run around and fall. Napkin vitiligo or diaper vitiligo is probably kevnerization underneath the diaper. Kids have really great treatment outcomes, so don't undertreat them. We should really offer treatments to our kids with vitiligo because they respond well. Kids often request treatment themselves by the age of 6. They're entering school. This is when they're self-aware and really kind of are more concerned about their disease. We use tacrolimus for the face and steroids for the body just for 1 out of 2 weeks, which is similar to what we do in adults. I like to use mometasone as a potent steroid. It seems to do well in kids. Phototherapy is okay if the kids can stand still and pay attention and not open their eyes in the booth and take their goggles off. And that happens at different ages for different kids. I find the age of 5 is probably a minimum. And we generally wait until adolescence for surgery so that we can avoid general anesthesia. Oral steroid therapies suggested by Dr. Tayeb and his colleagues were under the weight of 30 kilograms to use 8 milligrams of methylprednisolone on the weekends, and over 30 kilograms, 16 milligrams of methylpred. Diet and supplements come up a lot. Patients ask about this. What can I do? What can I eat? And there are some ideas. Ginkgo biloba, polypodium leukotomos has a little bit of data showing that it helps a little bit. There are other vitamins that may help. Right now there's limited data. We need to do more studies of this. And the problem is these are unregulated by the FDA. And so you can buy these, but you don't know actually if the product actually contains any of what's claimed to be in there. And so this is a major problem with studying this. So right now the jury's out. There are some that have been suggested, and you can find those in the table 1 of that chapter. The genetics of vitiligo has revealed a lot, I think, about the disease. Currently, 50 genes have been identified by a number of groups around the world, and most of the genes are involved in immune regulation, telling us that vitiligo is mediated by the immune system, and many of these genes are shared with other autoimmune diseases, really telling us that vitiligo is autoimmune, and the reason why other autoimmune diseases go along with it is because the genetic risk is shared. And the genes are telling us there's probably a crosstalk between melanocytes and the immune system, getting things going. In this figure, Dr. Spritz shows the overlap. On the top are all the genes that are, many genes that are associated with vitiligo, and then on the left are other autoimmune diseases, and the dots show overlap of where the other diseases have the same genes that are risk factors. And so this is probably why we see autoimmunity in vitiligo. The red dots in the bottom right are overlapped gene risk alleles with melanoma, but they're red because they're the inverse risk. So a risk allele for vitiligo is actually protective against melanoma, and that's an important, again, to recognize. We talked about that a little bit earlier. And finally, we're going to quickly talk about what causes vitiligo, because this is where the new treatments are coming from. Vitiligo starts, as we discussed, with stress in the melanocyte itself, which recruits CD8 T cells, the immune system, to come in and kill the melanocytes and cause white spots. Once we control this, we can get the melanocytes to grow back, and that's how repigmentation occurs. And so there are a number of treatments that target each aspect. The hope was that antioxidants would normalize stress. We're not quite there yet. Topical immunosuppressants suppress autoimmunity. Surgical treatments put the melanocytes back, and phototherapy does a little bit of both. It's probably why it's the best treatment. We found, looking at the genes that are expressed in vitiligo spots, both in humans and in a mouse model, that interferon gamma was the primary driver of vitiligo and autoimmunity. And we found that blocking interferon gamma, or its downstream induced protein called CXCL10, was able to prevent and reverse disease in mice. And so we thought that this was probably a good pathway to target for new treatments. This is really well supported by a case report by Brett King at Yale, who used tofacitinib, a JAK inhibitor, which inhibits interferon gamma signaling. It had a nice result in this patient over about 5 months. We published another case report using a different JAK inhibitor called ruxolitinib, and patient within 5 months had very nice repigmentation of his face, and incidentally, it dropped his CXCL10 levels, really suggesting it was working by blocking interferon gamma. So this is good proof of concept that blocking this pathway would be effective. Another group at Tufts recently published this paper showing that topical ruxolitinib JAK inhibitor works really well for the face, and this has prompted a multi-center clinical trial to test this drug in vitiligo as a topical, and we're going to participate in that trial hopefully soon. So finally, this is just a diagram. You can see this in the chapter. Vitiligo appears to start with CD8 T cells that make interferon gamma. That signals through the signaling cascade in keratinocytes that produce CXCL9 and 10 that signal through the receptor CXCR3. This creates a loop that keeps the inflammation going. And in red, I've outlined a number of drugs that have been developed by pharmaceutical companies. They've already been through phase 1 clinical trials and shown to be safe. And so we're hoping that this and many more drugs will change how we treat vitiligo patients. Once again, I just want to thank the contributors to this issue who did a great job and are excellent experts in vitiligo. And that's the end. So we want to move from here. If you can close, Tim, if you can close the poll and publish the answers. We're going to actually move over to the polls here and look at the questions that have been posted all along. And it looks like, let's see, so people answered this first question correctly. Maybe after I gave the answer, I don't know, but the effect of vitiligo on patients' quality of life is similar to psoriasis. And we treat psoriasis with all kinds of expensive therapies, and so it really speaks to the fact that we should be treating our vitiligo patients. Number 2, what is a clinical sign you should prescribe oral steroids? This is all over, and some people think you shouldn't prescribe oral steroids, 44%, that's the majority. I'm glad we had this question, because if you think about it, if patients have signs of active vitiligo and we don't slow that down and don't treat that, with just 3 months of low-dose steroids, they can triple their body surface area, and then you're starting at a much more difficult spot when you start treating them with therapy. So the answer is confetti macules of depigmentation. That's the only sign here that disease is active, and we'll use oral steroids to calm that down. Again, just for 3 months at a very low dose, and it seems to be pretty effective. What's the risk of vitiligo patients developing non-melanoma skin cancer compared to the general population? It's actually 3 times lower, so 50% got that right. Most assume that it's higher, and that's probably a reasonable assumption, but the data don't show that, which is good news for our patients. What's the most effective therapy for segmental vitiligo? That is surgical treatment. 38% got that right. It appears to be a permanent cure of the disease in patients with segmental vitiligo. And so to me, it seems like the most effective. It can even be first line, although it's not unreasonable to try these other therapies as well first. And then finally, what's the primary immune cell and cytokine responsible for causing vitiligo? The answer is B, CD8 positive T cells that make interferon gamma. 7% got that right. And this is important to recognize because the emerging treatments, the ones that we think are going to have the biggest effect, are going to be targeting that pathway. And thank you for listening. I now want to move on to some of the question and answers. Some of the questions that were posed by listeners. We probably won't get to them all, but I will do my best. First question was, what about home phototherapy, UVB home phototherapy? Is this an option? How safe and successful it is? And so there are phototherapy units that can be purchased and put in the home. They are very effective for vitiligo, in fact, and the units themselves they list for around $7,000. Patients who use this I prescribe this a lot, and patients get a great response. So they get actually pretty similar responses with home phototherapy as with a doctor's phototherapy. And although the doctor's phototherapy booths are more powerful and they probably work a little bit better, it's because patients are more compliant and they use their treatments more when it's at home that they get great responses. So I think that's a really useful tool for patients. Let's see, what else do we have? Aware of the effects of shingles vaccine on vitiligo patients. Currently, there's no evidence that the shingles vaccine or other vaccinations actually cause vitiligo or worsen the disease. Certainly, some patients could have. I've had patients who feel that they've gotten spreading of their vitiligo after getting any number of vaccines. It's hard to know if it's the vaccine for sure, because spreading of vitiligo happens all the time, and people are getting vaccinated all the time, particularly kids. But it's not unreasonable to ask that question. So vaccines induce the immune system. They activate inflammation. They're very good for us. They save our lives. But anytime you activate inflammation, similar to just falling down and scraping your knee, vitiligo can go to that location. So I would say that it's something to consider and thinking about, but there's really no evidence right now. Someone thanked us for our work in vitiligo. That's great. It's absolutely one of the worst diseases in terms of social impact, and I hate to compare it with other diseases because it's its own thing. But I think that the comment that it can be worse than cancer just speaks to how much this affects people. So thanks for that comment. Question: if a patient has vitiligo on multiple joints, hands, knees, elbows, has not spread, could it be segmental? And so the real characteristic of segmental vitiligo is that it's only on one side of the body. So if you have it on both sides of the body, if both elbows, both knees, both hands have vitiligo, then it is not segmental. It can be not segmental on both sides and stabilized though. So that sounds like that's what's occurring. What Mark Ruccolo is talking about, that the vitiligo is on both sides. It's not segmental, but it's just not spreading. And so that's reasonable. That can happen. We don't know why some people spread and others stabilize, and certainly after a long period of stability, it can start back up again and start spreading again. Let's see, next question. What known skin issues would cause vitiligo to occur from scratching due to itching? Any type of scratching could cause vitiligo to spread. If you see lines of vitiligo, that we think is due to scratching of the skin. So controlling itching is important anyway, because that also causes devastation for patients. Itching is a very uncomfortable feeling, and so we want to treat that anytime it occurs, not just to prevent vitiligo from spreading, but itching is pretty awful too, and that can be done with any number of topical treatments and steroids. Are systemic steroids recommended for children? Yeah, and so if you think about, we're using very low-dose steroids, and kids tolerate steroids really, really well. And so I think that the benefits of using oral steroids for just 3 months, orally, really outweigh the risks. And again, the risks, remember, within 3 to 6 months, vitiligo can spread from 5% body surface area to 15 or 25%, and then that's much more difficult to treat and can be devastating for patients. So yes. And you can read the children's vitiligo chapter in the book to look at the options for treating. Let's see. I'm just going to take a look at how many more. So we got way more questions we can get to. I'm happy to keep going if listeners are going to stay on and we have some time. Let's see. So question of a 4-year-old son with vitiligo on the buttocks. The skin actually is back to normal, so it seems to have gotten better. Will the same patch appear somewhere else? It's always possible. So when there's evidence of vitiligo, if it's truly vitiligo, then it can come and go. Usually it does not go away on its own. So one of the questions in this case is if the vitiligo is all over the buttocks and then it just reversed completely on its own, it's unclear if that was actually vitiligo, so it's important to make sure that that was the case. But it's good news either way because there aren't any spots anymore. Could it come back? If it was vitiligo, yes. So you can just keep an eye out, but it won't necessarily. And difficult, so there's a link that I'm probably not going to go to. It will take too long. Gluten-free diet. Right now there's no evidence that a gluten-free diet will help vitiligo. Gluten-free diets are great for patients with celiac disease because they're allergic to gluten. They actually have to follow that diet. Patients with vitiligo can have celiac disease, so if that's the case, certainly following a gluten-free diet is important. But right now there's no evidence that following a gluten-free diet will improve the vitiligo. I have had some patients that have done it, and a few have said, oh yeah, it helped. Most have said it really didn't help at all. So the jury, I guess, is still out. Laser hair removal, that question comes up a lot, and we don't know for sure because in theory it could induce kebnerization, injuring the skin. Technically hair laser removal is injuring the skin, and vitiligo could go to that location. In most cases though, vitiligo is not active, and so laser hair removal should be okay. And usually what I recommend to patients is that the laser hair removal just be done in a small area as a test spot. Give it a good 2 or 3 months, make sure no vitiligo went there, and then if there's no vitiligo, then go on and do the rest. Spontaneous repigmentation, it does occur, but not that often. Usually what people call spontaneous repigmentation is repigmentation that's occurred from sun exposure. So if it's happening during the summer and kids getting outside, playing in the sun, up here in the Northeast, it's the only time we get to see it. Going swimming a lot, going to outdoor camps, the sun actually will cause the repigmentation. As we talked about, they knew this way back in India 3,000 years ago. We talked about diet and natural remedies. I'd recommend maybe getting the book if you can and looking at that chapter. There are a number of them that may have some benefit, but on the whole, even the ones that may help a little bit don't compare to the drugs and the treatments that we have for vitiligo. So I usually tell patients, let's keep it simple, use the medicines that we know work, and if they really, really push and they want to try something, then ginkgo biloba and Polypodium leukotomos, both from plants, may be effective. What is autoimmune disease? So vitiligo is autoimmune. And goes along with some other diseases. You can read more about that in the chapter. Does sun exposure increase vitiligo? It does not cause the spread of vitiligo, but it can make it more visible. So if the skin is lightly pigmented and you get sun exposure and tan a lot, then the vitiligo is more likely to show up. But remember that the sun exposure actually helps vitiligo. That's one of the treatments. So how many procedures might you need for surgical treatment of segmental vitiligo? Sometimes you do need more than one procedure. You can get a great response. It almost never is 100% response. So if you get 90%, 95%, that might be satisfactory. If you get less than that, then certainly another procedure can be warranted. And we've seen patients who get two or three procedures afterward to get good results if they didn't get enough the first time. That can depend on the patient too, so we just want to make patients happy. So if we can do one procedure and get 95% repigmentation and the patient's happy, then we'll stop there. If they really want a second procedure to get closer to 100%, then I think that's reasonable. Can phototherapy cause cancer? PUVA, definitely. Psoralen plus UVA historically has increased the risk of skin cancer, particularly in patients treated with psoriasis. So far, it appears that narrowband UVB does not do that, and that's the great news. We've been using it for 20 or 30 years now, and there's really no evidence that it increases the risk of skin cancer. Let's see, so it's 1:05. I think I'm going to end here. I love answering questions, but I'm looking and there's 63 questions more, and so I'm afraid we won't get there. Thank you all for listening. We had a good audience, a good number of people, and I encourage you to read up more about vitiligo. For the dermatologists out there who are listening, we need vitiligo experts. Consider joining the team, and it's a lot of fun, and it's a great group of people. Thank you very much.
Thank you. We would like to thank Dr. Harris for presenting this exciting informational webinar activity, and we hope that you will be able to use what you learned today in your area of practice. At this time, I would like to thank our presenter and today's audience for participating in our webinar. Thank you for joining us. I hope to see you at a future webinar.